Morning to all and big greetings from Kolkata. Our instruction course will be Trabeculectomy Empower the Basics, and we are basically celebrating the 66th year of this surgery, and this has been so consistent, it has never lost its position from the group of glaucoma surgeries whichever have come into market. It's still the gold standard. Though it has undergone revolutionary changes, and we still have to embark on safety of augmentation and different steps. And we have a galaxy of 6 to 7 speakers which will touch upon various steps, safety mechanisms, resurrection of the procedure, complication management, and also we have Dr. Shams Noman from Chattogram, who is going to give an insight about a collagen implant use in trabeculectomy. Without making further delay, I would like to call upon on stage Dr. Orijit Mitra, Dr. Chandrima Paul, Dr. Suchanda Shor, Dr. Sharmila, and Dr. Shumit Chaudhary. Our first deliberation about mitomycin C in trabeculectomy, how much and how long, will be delivered by Dr. Orijit Mitra, who is a consultant glaucoma services, Disha Eye Hospital, West Bengal. Orijit.
Good morning, everybody. So my presentation is on mitomycin C in trab, how much and for how long. I'd like to start by presenting this particular slide where I'm going to focus on the conjunctiva, which is probably the most important structure which determines the success of a trabeculectomy. Now, the problem nowadays is that we have a huge number of drugs which are being used for a long duration of time. What that does is it leads to something called a pseudo-pemphigoid or a drug-induced ocular pemphigoid. What that means is there is a reduction in the number of the goblet cells, there is epithelial keratinization, squamous metaplasia, loss of microvilli, etc., etc., etc. So this conjunctiva is no more normal when you're subjecting it to a trabeculectomy, and it's called an activated conjunctiva. And drugs like pilocarpine, beta blockers, and prostaglandin analogs are notorious for causing this. So this is going to impact the survival of the bleb and the success of the trab. So what can you do to deal with this? One is the pre-treatment with steroids. So there have been studies where they've used fluorometholone or ketorolac for a month preoperatively, or they have used prednisolone or dexamethasone for 2 weeks preoperatively, stopped the anti-glaucoma medication, and kept the person on oral anti-glaucoma meds. But does that really help? The answer to that is unclear. The second option is obviously the use of antimetabolites. Nowadays, I think everybody uses either mitomycin C or 5-FU, although 5-FU has now gone out of vogue. Problem is, when you're using mitomycin, there are certain questions. A, what is the actual dose of MMC delivered? B, what is the effect of irrigation? C, does the dose depend on the size of the sponge, etc., etc. So I'll just touch on a few of these points. One, what is the concentration of mitomycin and the time of exposure that is required? So when mitomycin C first came into being, people started experimenting with it. So concentrations of 0.5 milligram per DL, 0.4, 0.2, all were used for varying durations of 1 minute, 2 minutes, 3 to 5 minutes. Now this was a particular study which showed that if you keep a sponge soaked in mitomycin C for more than 3 minutes, then it reaches a plateau phase. That means there is no more release of mitomycin C from the sponge. So basically keeping the sponge for more than 3 minutes is not required. So the ideal time is around 1 to 3 minutes, which depends upon the particular type of case. B, what is the actual dose of MMC delivered? So for this, they did a study. This was done on 5FU. There was one more study on mitomycin also, where what they did was they kept the sponge at site 2. Then they took conjunctival as well as scleral biopsies from site 1, 2, and 3. And what they found was that at site 2, where you're keeping the sponge, the concentration of mitomycin C was the highest compared to sites 1 and 3. But what was interesting is that if you look at the conjunctival concentration, if the sponge is of the smaller size, that's 3.5 into 2 mm sponge, it released more mitomycin C into the conjunctiva compared to the sclera. So if you're using a small size sponge with a high concentration of mitomycin, it can cause a mitomycin C burn. So ideally, if you have a bigger size sponge, then less concentration of mitomycin C is released into the conjunctiva, more is released into the sclera. So probably a diffuse area of perforation of mitomycin C is required. Next is the type of sponge. Does that affect the amount of mitomycin C which is released? And the answer to that is yes. Because earlier, they used to use these Altomate sponges which released a huge quantity of mitomycin C. However, Wexel and Merocel sponges are nowadays used. Weck and Mero are both good. Merocel sponge have a property of degradation, so probably Wexel sponges are the best. Does the size of the sponge have an impact? As I've already mentioned, yes, if you have a smaller sponge with a higher concentration, it will lead to a conjunctival burn. So this is another study which was done on mitomycin, where what they did was they took the PVA sponges and they cut it either 6 millimeters from the tip or 8 millimeters from the tip. And they subcut it into 3 pieces. They studied this and compared it with the PVA fluid wick, which they cut into 4 into 4 mm pieces, and a gelatin sponge, which they cut into 3 into 3 mm, and 5 into 5 mm pieces. And what they found was that all these different sizes released MMCs of different concentrations. They absorbed MMCs of different concentrations, they released MMCs of different concentration. So probably a PVA sponge cut 6 millimeters from the tip is the best way to proceed. Now, when you want to irrigate, how long and how much fluid do you need? So is it 15 ml, 20 ml, 100 ml, or 250 ml? I'm sure everybody has a different parameter, but the Moonfield Safe Surgery system says that immediately after the sponge removal, irrigation with 20 ml of BSS is to be done. Now, after all these came into being, they had this Mmc Titration Protocol, where they classified it into points. This is readily available if you search on Google, where the age factor was taken into account, the race, whether it has undergone a PCIOL, whether the conjunctiva was virgin or not, etc. was taken into account. And then each case was assigned a score, and then the concentration and the duration was graded according to that. So this was the Mmc Titration Protocol. But in spite of all these checks and balances, we all routinely encounter blebs like these in our OPDs, which are extremely dangerous and which are disasters waiting to happen. So what's new? What's new is that nowadays, the injection of mitomycin C over a diffuse area is probably the way to go. So the concentration, which is 0.4 milligram per ml, which is what most of us use, that is taking a 2 milligram per ml vial, dissolving it into 5 ml of water. Then you take 0.1 ml of that, add 0.1 ml of lignocaine, and you get a 20 microgram concentration. Or you can dilute it further, take 1 ml of 0.1 ml of this, add 0.3 ml of lidocaine, and use 10 micrograms of that. So probably injecting it is going to be beneficial because you're going to know the exact amount. The same dose is going to be delivered to every patient every time, and it is going to be over a wide diffuse area. Just to visualize it, you can use ICG mixed with the mitomycin so you can see the area where it's going to go. This is going to be discussed in detail by Dr. Dipanjan Pal, so I've just touched on this. So this is where we stand. That is pre-treatment with steroids or non-steroidal anti-inflammatory drugs, using antimetabolites like either 5FU or MMC during surgery, and probably a wait for future drugs like drugs from the TGF-beta family or matrix metalloproteinases in the future. Thank you.
Thank you, Arijit, for your such a wonderful descriptive talk on Mitomycin C. Our next speaker will be Dr. Chandrima Pal, who is a doyen of ophthalmology and glaucoma, and we have learned so many things, so many years of experience in surgery. She's a director and head of glaucoma of BBI Foundation, Kolkata, India. And she will talk on standard trabeculectomy step by step.
Thank you, Dr. Dipanjan, for the kind words. A very good morning to all of you, and thank you for making me a part of your course. So, standard trabeculectomy, practical guide, step by step. So glaucoma surgery, as you just heard from Dr. Arijit, has traditionally been all about efficacy, and serious safety issues have promoted evolutionary improvements. So to create a lasting filter, we need to understand the following with respect to trabeculectomy: the essential principles of surgery, the prevention of complications, recognition and management of intraop, early and late post-op complications. Trabeculectomy is an excellent procedure when it succeeds, and to ensure it does, you've got to avoid many landmines along the way, like conjunctival buttonholes, over and under filtration, and hemorrhage. So over the years, we've seen that surgeons do well and could do better when performing this procedure. In came the Moorfield Safe Surgery System of trabeculectomy. So Dr. Kaur and colleagues outlined improvements in glaucoma surgery for better control of lowering pressure with fewer complications. These improvements have developed into the Moorfield Safe Surgery System with improved exposure, increasing the surface area of antimetabolite application, modified scleral flaps, and fornix-based incisions with a dramatic reduction in cystic blebs and long-term complications. And I had the privilege of being with Dr. Kaur to see these surgeries during my training at Moorfields. So, preoperative trips. I have no financial interest in that drug, but if you instill a drop of brimonidine onto your conjunctival sac just before you start surgery, it could show you your way because it constricts the blood vessels and your field could be less bloody. So intraoperative tips, that's the Weck cell fluid dissection to your right. It can help avoid complications by making the conjunctiva more mobile. Then lift the conjunctiva with non-tooth forceps. That's just making an incision into the conjunctiva. I generally do fornix-based flaps, but it depends on which surgery you are comfortable with. Mitomycin C I apply in a wide pocket under the conjunctiva at a concentration of 0.2 or 0.4 mg per ml, and I apply it for 2 minutes. I generally don't vary my time, though in Moorfields they apply it for 3 minutes, but I do it for 2 minutes. I generally vary the concentration according to my patient. And that's a hammer kind of a thing that you see I'm taking out. I've designed that actually. I call it the Conjunctival Separator, and it's available with the companies. So to provide a non-touch technique of applying MMC. Then the scleral flap, the horizontal incision parallel to the limbus is made, dissecting a partial thickness scleral pocket. Two sides of the incision are cut using specially designed scleral scissors. That's also designed by me. That's the scissor. And you cut the sides without completing the side incisions right up to the limbus. This helps in directing the aqueous backwards over a wider area, encouraging a greater posterior flow and a more diffuse bleb. So a perpendicular, clean, non-shelved incision at the sclerolimban junction, and the ostium is punched out with the Kelly's punch. I always use a small punch. If required, I do 2 punches, but I generally use a 0.75 diameter punch. And that's the peripheral iridectomy done with scissors parallel to the limbus. Should make sure that it's a complete iridectomy. And the scleral flap sutures, these are releasable sutures. They're relatively easy. Take your needle in through the limbus, then through the conjunctiva, and finally through the lips of your scleral flap. Make 4 throws and take the loop out so that you can titrate the IOP post-operatively. And now with the use of mitomycin, you can actually titrate that right up to the 3rd or 4th week of surgery. So that's your scleral flap releasable suture. And conjunctival closure, there is no pointer out here. So essentially done using round bodied needle rather than spatulated, and continuous 9-0 nylon sutures are done with buried knots. So just to tell you a little bit about biodegradable Olagen matrix implant versus MMC, this is a study that we did. 20 glaucoma patients, 30 eyes were assigned to trabeculectomy with MMC or Olagen. Olagen implant could be a new safe and effective alternative to MMC with similar long-term success rate in eyes with moderate glaucoma. That's what our conclusion was. And the technical pearls are releasable sutures, Olagen position, suture release, choose myopics, and you can use it for repeat procedures. That's a small thing. I've made my trabeculectomies much smaller, and you just have to put in that Olagen there, and simply after you've completed your surgery, and then this just suture up your flaps of the conjunctiva. So that's it basically. And this I move ahead, phacotrabeculectomy. So a little per-operative surgical pearls, that is, I always use injection mannitol 20%, 100 ml just before surgery. Consider topical or parabulbar anesthesia. Never use tooth forceps to handle the conjunctiva. Aim for a watertight conjunctival closure. Lower high preoperative intraocular pressure, and never leave the operating room with an unclosed leak. So early post-operative period, the points to ponder: digital massage helps in formation of the bleb, laser suturolysis and releasable sutures are useful techniques. Tackle one at a time, one suture at a time to avoid hypotony, especially in eyes that have received antimetabolites. Early recognition of signs of scarring and appropriate treatment improve the success rate of trabeculectomy. Always try conservative treatment with encapsulated blebs. Aqueous misdirection is a difficult complication to manage. The best approach is to prevent the initiating factors like sudden shallowing of the AC in high-risk eyes. And common cause of serous-choroidal detachment is a conjunctival wound leak. Identifying the primary cause and appropriate treatment should be the first step of management. And with that, the late post-operative complications, Dr. Shumit Chaudhary will tell you all this. So just early post-operative hypotony leads to chronic hypotony. So avoid low IOP initially. Patient's education is important to minimize risk bleb and infections related to it. Failure of the bleb can occur at any time following surgery. So post-surgery follow-up is a must for all patients. Tear film disturbances are common with symptomatic blebs, so give them artificial tears, and immediate and aggressive treatment of bleb infections can salvage the eye. So trabeculectomy still remains the gold standard, as Dr. Dipanjan Pal told you at the beginning of the session. We are into the 66th year, and it's still the gold standard as the initial surgery for glaucoma. Technical modifications to the trabeculectomy combined with the use of powerful antimetabolites actually help you have greater control of both the operation and post-operative scarring. The Moorfield Safe Surgery Systems development is based on the need to improve consistency. And trabeculectomy with MMC is a complex operation requiring high degree of manual dexterity and extensive glaucoma experience. But I would encourage those of you in the audience who do perform glaucoma surgery to continue to regard trabeculectomy as your initial choice. Thank you for your attention. And I invite you to Kolkata for the next AIOC in 2021. Thank you very much for your attention.
Thank you, Dr. Chaudhary Paul, for your illustrious talk on trabeculectomy. Leave it.
Hello. Now, Dr. Dipanjan Pal, Senior Glaucoma Consultant, Disha Eye Hospitals, Kolkata, Chief Instructor of this course, will be sharing important pearls regarding safety-enhancing modifications in trabeculectomy.
So I will just touch upon few videos, and where I found it exactly important to have few skills and few important pearls just to increase the safety of the surgery. And the first of all, we need to have a proper analgesia, and many a times we see that, you know, we do not have we do not have proper analgesia in many patients. I personally feel that you must learn subtenal anesthesia, and that is going to give you a lot of leverage. If you can just nick over the inferonasal area of the conjunctiva, make a small nick, and you can pre-infiltrate with lidocaine so that all the more comfortable for the patient. Go below the tenons and keep a long needle, go slowly, and then raise the conjunctiva, and patient is absolutely comfortable and you are also comfortable during the procedure. Another thing I have seen that many times during peripheral iridectomy, we tend to pull the iris so much that while cutting, we go to almost to the root of the iris. So the moment we go to the root of the iris, we can have something like this bad things that happens, which has got, very bad after effects on Gleb, that is severe hemorrhage. Sometimes it is very difficult to control. So on the other hand, if you just do not do like that, don't pull the iris so much to your wound. Just after finishing it, just pull it up and lightly cut the iris so that you don't have a bleeding. Don't pull the root. The flab dissection has to be extremely careful. You have to be extremely careful during flab dissection. First of all, at least 4 to 5 millimeter base you need to create and dissect the flap so that you do not go extremely deep, do not go extremely superficial, be at the same plane, make the flap little thicker and then go at least 1 millimeter into clear cornea. And here you see I am not going to the extreme edge of the triangle. If you avoid to go to the extreme edge of the triangle, you actually reducing the chance of overfiltration. So you are actually ensuring posterior flow, which is from the apex of the flap. And in the second video, I would try to impress upon thing. Sorry, it's not running. Yes. Always hold the flap with an instrument called Pierce-Hoskins forceps. It doesn't cause a hole in the flap. This is the forceps. Please use this forceps. Otherwise, any tooth forceps can cause a hole in the flap. You can also use bark upper knife 15 number. Please use the tip of the knife to get the maximum good effect. So what happens if you are very generous and sometimes you do not know how sharp your instruments are? So while moving or doing the flap dissection, sometimes you just go too fast and you can have a premature entry. So as trabeculectomy or ostium is essentially a premature entry, it doesn't make much of a difference. You can actually recover the case going from a side port, taking the iris out, pushing a little pilocarpine to get the iris constricted, making an iridectomy from there, and then, taking the iris out of wound once again. This is a little salvage work, doesn't look very nice, but actually this patient was doing very well postoperatively. That you can ensure, and then the normal procedure. Pre-placed suture is of utmost importance, specifically when you are dealing with young patients who has got lot of tenons. And sometimes if you have to do a staged sutural lysis or stage organ laser sutural lysis, the tenons are so thick, you do not see anything with your slit lamp. So you have to have a pre-placed suture which will act as a releasable suture in the post-op period to control the intraocular pressure. When we use Ologen, if we are planning to use Ologen, we have to give a single apical releasable suture. So that is the only suture that keeping the flap secured. So it is preferable to give at least 4 throws. When you are using Ologen, please use for your safety. Otherwise, you might land up into an overfiltration. And this is how we put Ologen, which will be beautifully described by Dr. Shams Noman in our keynote address. And the conjunctival flap suture has to be extremely tight, because if we have early leakage, that ultimately goes into all sorts of complications of hypotony, choroidals, and late blade failure and things like that. After putting 2 wing sutures on 2 sides, I will impress upon to put a central suture at the limbus, ideally by tenonylon, and knots to be buried like this. This ensures that your limbal zone is absolutely safe and there is absolutely no leakage. You give just 2-3 throws and then carefully bury it. And at the end, we will show you an oh my god situation. After finishing a trabeculectomy, after finishing PI, I was just washing the pigments and see what happened. So we had a vitreous from the superior part where the zonules are empty. So while if you want to clean the pigments, be very gentle. Otherwise, these bad things can happen. Thank you for your kind attention. I will call upon our next speaker, Dr. Suchandar Shah, who is Senior Consultant Glaucoma Services, Disha Eye Hospital, who will talk about nurturing the blebs.
Good morning, everybody. Thank you, AIOS. Thank you, Dipanjan, for giving me this opportunity to present here.
Ma'am?
What happened?
Ma'am, you could present from here.
It's there. Go.
Now hello. The trabeculectomy has been done. The ostium has been created with extreme care. Now the challenge is to keep the ostium patent. The bleb has been born. Now to take care of and to support the bleb to develop from when it is born to 4 days to 3 weeks and ultimately 3 months when we have that optimally vascular diffuse bleb with microcystic changes that is fully functional, and that is what we all aim at. To nurture and bring the bleb to this point needs a lot of support, because wound healing is the key determinant of the bleb quality and outcome. And if we can modulate this wound healing response when it is going against us, going in a way which is not favorable, then if we can modulate this healing, then we can maximize the surgical success. The three potential sites for outflow resistance is internal sclerostomy, external sclerostomy, and maximally the episcleral subtenon's capsule. During healing, if subconjunctival fibrosis takes place, that leads to scarring and suboptimal filtration, and then insufficient lowering of IOP, and the end result is a failed bleb, even after we have tried so hard to keep it functional. But to our advantage is that these blebs are dynamic and remodeling takes place over a time. So if we see that things are not going favorably, we have possibilities of doing certain maneuvers so that we can control this remodeling and sometimes salvage blebs and make them functional. The end result of all our efforts can be a diffuse filtering bleb, the ones that we actually want, or it can be an encapsulated bleb or a cystic bleb, and sometimes, unfortunately, despite all our efforts, it can be a flattened, flat bleb. Post-operatively, the trab has been done. The first priority is to control inflammation and infection. And topical steroids is the major post-operative tool to prevent that scarring. Frequent optimum post-op reviews, because it is during these early stages that we can detect bleb scarring by looking at those excessive conjunctival injection, the corkscrewing of the vessels, flattening of the bleb, encysting of the bleb. And if we can catch them early at this stage, then we can do certain modulations to make them functional. We have to be very alert for signs of post-operative complications. Detect the signs early, do timely, correct interventions, and also control any infection if it happens. I will not be going into the details of this, but we have this nomogram which tells us that what are the signs if we are alert, and we need to analyze to find out which way the bleb is going. Scarring. Scarring, if detected early, we can do a lot of OPD maneuvers which helps to salvage the bleb in its journey towards maturity. So if the internal ostium is patent, which we need to check out first, if there is an iris adherence at that point, then we need to intervene surgically and reposition the iris. But if the ostium is patent, the bleb is flat, then it is a pointer towards early scarring or low filtration. Digital massage, removing of releasable sutures, or doing laser suture lysis, needling of the bleb, with or without antifibrotic injections, are very helpful procedures. I will not be talking about needling, which will be taken up by Dr. Sharmila. Removing releasable sutures is a very simple technique that can help us to salvage many a bleb. So routine use of these sutures in our surgery is very beneficial. A bleb massage aims at fish mouthing the posterior opening of the scleral flap with a digital pressure at this point, which helps to fish mouth the opening and allow aqueous flow. And this can be done digitally, or it can be done with the help of a blunt instrument or a cotton bud. Here we are showing a video. The patient is asked to look down, and digital pressure is being applied over the eyelid at the posterior part of the trabecular flap. And it's not very clear, but the bleb has formed. So making the patient look down, but applying optimum pressure. It should not be that much that we create strain on the conjunctiva and loosen its sutures. Suture release can be done with the help of lasers. Or is it, can you see? Yeah. With the Pierce-Hoskins lens, the suture has been focused and we are applying the laser beams, and we will see that here the suture has got cut. We applied digital massage and there the bleb forms. This video is been shared by one of my colleagues, and the ways of giving releasable sutures varies from doctor to doctor. Here he believes in giving releasable sutures, which he has released one of them, and then applying digital pressure, and here the bleb forms. But this was an older technique. Now we prefer to give releasable sutures after taking a corneal bite, because leaving sutures like this can give us windshield wiper syndrome. Here, because the sutures are free to move and they cause a corneal epithelial defect at this space. So the type of releasable sutures that was shown by Dr. Chondrima or Dr. Dipanjan is the way to go, that we take a bite in the clear cornea first so that the loose ends do not remain dangling. But time of release of releasable sutures must be optimum, because too early a release will lead to hypotony, which is going to be very difficult to manage. Again, too late a release after the fibrosis has taken place is also not helpful. Gleb leakage. If we have gleb leakage, we can follow any of these to manage. In this case, it was a gleb leakage close to the limbus. So we had applied a 16 millimeter bandage contact lens along with doxycycline for 2 weeks, which helped us to heal this gleb leakage. But in this case, we were not that lucky. So we had to do a timely surgical intervention, because this was the gleb leakage and it was quite big. And we realized that a BCL would not work, so we did a surgical intervention. So once we dissected out the diseased conjunctiva, we found that the sclera was also leaking, so we put a scleral patch and we did a conjunctival advancement. So nurturing the bleb at the right time, doing the right modulations can help us salvage many a problem. Thank you.
Thank you, Dr. Suchanda. Now, Dr. Sharmila, who is a glaucoma consultant from Arvind Eye Care System, will take us through resurrecting a failing filtration. We'll cover both the external and internal needling of bleb.
Good morning, everyone. At the outset, I would like to thank Dr. Dipanjan for having me in this course. For the next few minutes, I'm going to be talking about resurrecting a failing bleb. As glaucoma surgeons, we all would like to have a good functioning filtering bleb. However, there are situations where we do face problems with failing bleb. So how do we identify them? Number one, these blebs are generally flat and low, they're vascularized, they don't have microcysts, and they're usually present with high intraocular pressure. So when and why do they fail? They may fail early, that is in the early postoperative period, that is within a few weeks, or they may even fail very late, a few years after the surgery. Most important reason for failure is, as the previous speakers have discussed, it's mainly the subconjunctival fibrosis. And there are certain situations where we may have to anticipate the failure. For example, these are eyes which are usually inflamed, and they generally use long-term use of anti-glaucoma medication causes alterations in the conjunctival cytology that may predispose to failures. And there may be also complications due to the obstruction of the ostium because of the blockage by the iris, by blood clots or vitreous, and also due to the tenon cyst. So early bleb failure. Early bleb failure, you can see something which happens in the early weeks, like within 2 to 4 weeks, and most importantly, it could be because of the obstruction or it could be because of the subconjunctival fibrosis. Sometimes it could be even because of an imperforate Descemet's membrane where you do not really do a punching, which is including the Descemet's membrane. It could be also because of a tight sutured scleral flap, or it could be because of a block, which is ciliary or pupillary block. So how do we rescue? As discussed by Suchanda, we have to hike up the steroids, we have to give ocular massage, we have to do a laser suturolysis or remove a suture, and sometimes people practice using adjustable sutures which could be adjusted, and eventually we may have to go for bleb needling. Ocular massage, she's already covered ocular massage, so I'm going to skip this, but I'll just show this video. So you have to give a gentle firm pressure over the upper lid just adjacent to the scleral flap. You have to be very patient, and a gentle 15-second on pressure and a 30-second off is important. You can see a small area where there is an elevation. Once you see that, continue giving the firm pressure until there is a diffuse elevation of this subconjunctival space. So this is how it is. So these are usually very helpful in the early postoperative period. And then laser suturolysis, which again she has clearly told. So whenever you do a laser suturolysis, do one at a time. And again, you have to give massage, check for the elevation of the bleb. If it is not happening, then you may have to add another laser suturolysis at the same visit. And always check the intraocular pressure. And these patients are generally needed to be followed up quite frequently, like within 2 weeks, every 2 weeks you have to follow them up. Sometimes you do face obstruction of the ostiums, which can happen with the iris. So you use pilocarpine, see if it is constricting, and if it doesn't, then maybe you have to take to the OR, make a side port, inject pilocarpine, use viscoelastic, and gently sweep, like what was shown, gently sweep the iris from the ostium using a cyclodialysis spatula. Bleb needling, when, where, and how. When do we do bleb needling? In the early postoperative weeks, whenever there is a failure, or it could even be done even many years after surgery. The only prerequisite is you need to have a patent ostium. So always do a gonioscopy, ensure that there is the ostium is patent, and then we can do a needling. So the level of needling, it can happen like because of the fibrosis where it is. It can be either subconjunctival or episcleral, it could be subscleral. Sometimes you may have to, there may be some membranes which is covering the ostium, so that also has to be perforated, so you have to enter the anterior chamber. It's always mandatory to do under aseptic precautions with better visualization, so I would recommend to do it only in the OR, although there are people who do it in the slit lamp. Late bleb failures, again, it could be because of the extensive fibrosis which happens very late, or it could be because of the internal obstruction of the ostium where you need to do an internal revision. However, the late failures, generally, if it doesn't respond to needling, one may have to go for either a repeat procedure, either a trabeculectomy or a tube, and nowadays there is this new kid on the block, which is the micropulse, which can also be tried. So the external revision of, is usually done under the microscope with better visualization. First, inject a local anesthetic using a 25 gauge cannula, and then use a visco, which is loaded on the tuberculin syringe, and gently make movements in the subconjunctival space, cutting out all the fibrous tissue, to and fro movements. You can see a gritty feeling which you can just keep cutting the tissues. It gives a sensation of, fulfillment when you cut those tissues, and you see there is, the end point will be the percolation of aqueous and elevation of the bleb. And after you do this, you inject viscoelastic. This viscoelastic acts as a barrier to prevent the injection of 5-FU or MMC, which would be done posterior to the injection of the viscoelastic. So this will not allow the entry of this antimetabolite into the eye. This is subconjunctival, which was demonstrated. Sometimes there may be a free area in the subconjunctival space, but however, there may be a subscleral, there is below the scleral flap, there may be fibrosis. So you may have to redirect the needle and go under the scleral flap and enter it into the anterior chamber. there are situations where even in ologen eyes, where you really don't have access to remove these sutures, and they also tend to fail, and eventually we may have to try some needling procedures. Here you can see that the ologen has seen very close to the limbus. So here you go posteriorly. You go from the posterior, you start the needling and inject 5-FU at the end of the procedure. This is a video which was shared by my friend Jayant from SNEC. They do needling with AC maintainer. Doing a needling with the AC maintainer is really very nice because it keeps the eye firm, and you can always maneuver it, and you can see that there is a good flow of aqueous, and you have a good firm eye to do the needling procedure. And this is an overlay with the OCT. So he has done it with the overlay with the OCT on his microscope. So this is a bleb which was needled after 10 years of trabeculectomy. He's going posteriorly. So advantage of this AC maintainer is you don't have a shallow anterior chamber, so you can just clearly keep going inside. And you can see that in the OCT there is good bleb forming and an improvement in the subconjunctival space. At the end of the procedure, just form the AC, and you can see a good bleb here. So the success of needling has been reported to be around 50 to 75% in the first year. However, it just comes down in the subsequent years to 30 to 50%. And there are some complications like hypotony, shallow chambers which can happen immediately. There may be also bleb leaks, hyphemas, and subconjunctival hemorrhages. Which one to use, MMC or 5-FU? There are reports saying that MMC appears to have a better efficacy when compared with 5-FU as an adjunct to needling in failing blebs after trabeculectomy, requiring only fewer repeat needling procedures. This is a video of the internal surgical revision. You do it in the OR again. You inject local anesthetic. Make a side port, inject viscoelastic, use a cyclodialysis spatula. You can do this under visualization using a gonioscope. Gently go through the ostium, pierce the ostium, and go into the subconjunctival space. This can be done even with the needle, but doing it with the cyclo is more safer. The same way you can make a side port on the other side to have a better coverage on the opposite zone. So tenon cyst is also something which happens recurrently, and it happens mostly in eyes which have been on long-term use of anti-glaucoma patients, young patients, and use of limbal-based flaps. Here again, you start on anti-glaucoma medications, bleb needlings, and most importantly, these eyes respond only with the surgical excision of the cyst. And repeat trab is an option. If at all a trab was done elsewhere, we really don't know whether they've used antimetabolites. Maybe one can consider using antimetabolites at a higher dose with a prolonged exposure, which was clearly shown by Arjit. They all need a frequent follow-up to see if they fail, because subsequent trabeculectomy, generally the success is less compared to the primary trab. This is a study which we had done, and we have reported our outcomes on repeat trabeculectomy on 40 eyes, and we found that using a high concentration and a prolonged exposure according to the individual risk factor, it could play a crucial role in helping the success, and it's definitely a viable option before planning a tube surgery. The take-home message is reviving or resurrecting a failing bleb is like reviving a sinking ship. So you have to identify the signs of failure. Early intervention is very important. Frequent follow-ups are mandatory. Bleb needlings with antimetabolites is a very good option. It improves the success by 60%. However, whenever there is a post-needling failure, we shouldn't be waiting too long, but we have to plan for a repeat procedure in the form of a trab or a tube, or even try for a micropulse. Thank you for patient hearing. These are my acknowledgements.
Subtenon injection of MMC, is it a boon? Dr. Dipanjan Pal.
no financial interest. So is it the boon? Is it the future of mitomycin C augmented surgeries? So why injection? Because sponge has given unreliable and inconsistent absorption of mitomycin C into sponge, and there is always a worry of leaving behind bits. And we have seen a localization effect, and there is inadvertent stretching and tear of suboptimal tissues. On the other hand, mitomycin C injection used preoperatively has precise delivery of the desired amount of drug, and there is no worries of leaving behind a sponge. There is wider and uniform application of mitomycin C and a shorter surgical time. There is enough evidence in the literature regarding the use of mitomycin C injection in blade needling procedures with considerable success, and injection mitomycin C has been superior to few in published studies, and there is a proven long-term safety. Dr. Khoury et al. Has already published recently a paper on intraoperative injection of sponge applied mitomycin C during trabeculectomy, which was a one-year study, and they have said that from baseline, almost more than 46.8% of injection patients had achieved success of intraocular pressure control, defined as 30% of eye reduction from baseline when compared to 37.8, which was rather low. And also, Pakravel et al., they have come out with a 3-year-long study on treatment outcomes of mitomycin C augmented trabeculectomy, subtenon. They have actually used intratenon injection versus soaked sponges. And they have found that although success rate and intraocular pressure reduction were comparable with both techniques, blade morphological parameters were more favorable after intratenon injection of mitomycin C. So, with this background, we did a study of non-comparative and retrospective case series of 39 eyes of 39 patients of combined phaco-trab, who completed minimum of 1 year period of follow-up. Included patients with age more than 40 years, mild to moderate visual field damage and deterioration on MTMT with visually significant cataract. Excluded patients with complicated cataract, intraoperative general dialysis, vitreous loss, trauma, NVG, etc. And we did a comprehensive ocular examination with Goldman appellation tonometry, gonioscopy, fundus, and automated perimetry at baseline. And all the cases were done by me with 20 microgram Mmc injection, triangular scleral flap, single apical 10 or nylon fixed suture, conjunctiva A to vicryl. And we did blade manipulation 3 days onwards up to 4 weeks, and followed up the patient at 3 days, 1 week, 2 weeks, 1 month, and then 3 monthly up to an year. At each visit, we did the same comprehension slit lamp examination, intraocular pressure measurement with GAD, and we did blade morphological assessment with IBAG's blade appearance grading scale. So how do I prepare the mitomycin C before injecting? I take 5 milliliter of balance salt solution, mix it with 2 milligram of MMC powder that is commercially available. 0.5 ml of the mixture, we mix it with 0.5 ml of lidocaine. We take 0.1 to 0.2 milliliter is taken for injection ultimately, but here we have used all cases of 0.1 ml and concentration becomes 0.2 milligram per milliliter. And this is the surgery. So we start with the injection. I am sitting on the temporal side of the patient, and we use a 30 gauge bevel down needle around 7 to 8 millimeter from the limbus, and try to keep this preoperative MMC blade as far as away from the limbus, just to save the limbal totipotent cells so that we do not get a leakage, and then complete the phaco in the usual manner from temporal side. Put an intraocular lens, finish it off, close the wound with a suture, and then coming superiorly, finishing up the trab in the usual manner. Single intraoperative suture to close the flap, 10 on nylon, and close it with a 8 of vicryl. So the outcome measurement was we defined success at 30% or more reduction of intraocular pressure from the preoperative level, where there was no need for further glaucoma surgery or additional medication, and there was no loss of PL. And we defined glued blebs at blebs with height more than h2, extent more than 3 clock hours, and poor height less than h1, extent less than 2 clock hours as per IBAG's grading system. The failure was defined as poor bleb with more than 2 additional medication at 1 year, loss of PL and reoperation for glaucoma. The baseline characteristics, we had a mean age of 60 plus years, where 60% were men. Preoperative intraocular pressure was 24 millimeter mercury, and the mean preoperative intraocular pressure of 24 millimeter of mercury was reduced to 12.56 at 1 year, and 30 eyes recorded, that is almost 77% recorded 30% reduction from the baseline, and 22 eyes achieved 50% reduction, and there was significant reduction of glaucoma medications, obviously. And coming to bleb morphology, we saw good bleb morphology in almost 80% of eyes, poor in observed in four eyes. But interestingly, and with a word of caution, we saw large area, that is more than 4 clock hours of avascularity, that is V0 blebs, in almost 8 eyes, which is a big number, and probably we can reduce the number by keeping this MMC bleb as far as away from the limbus as possible. And these are few complications like cystic change, subconjunctival hemorrhage during injection, large areas of avascularities and all. So we did some postoperative interventions, like 2 eyes presented with early wound leak. So we had given bandage contact lens and managed them conservatively, did bleb needling for 3 eyes, and we used the half strength of mitomycin C, that is 10 microgram. 4 eyes with poor bleb morphology required more than 2 additional medications, so they failed. And we had 2 eyes with early hypotony and 1 with late hypotony, and 1 bleb failed following late hypotony and choroidal detachment. To discuss, the success rate of our cases was around 77% with failure rate of 10% at 1 year, which was consistent with results of previous studies published. The surgery produced 50% reduction of mean intraocular pressure at 1 year, which is lower considering previously published studies, and 20% of the glued blebs have large avascular zone. And to conclude, subtenant injection is time-saving, effective, and probably a safer alternative, and it definitely produces favorable bleb morphology and function, and large areas of avascularity in significant number of patients may raise concern in the long-term safety of the procedure. Thank you for your kind attention. I will now request our veteran of Eastern India in glaucoma, Dr. Sumit Chaudhary, to take us through complication and management of trabeculectomy. He is senior glaucoma consultant of Disha Eye Hospital and Eye Care Services in Kolkata. Sumit, here? Okay, I will open it for you. Which one, this one? I am not able to control it. He is controlling it from there.
Thank you, Dipanjan, for inviting me in this session. And for the last 1 hour, you are seeing the good trabeculectomy and success of the trabeculectomy. But one thing is that trabeculectomy operation is against the wave, because any operation we want a good healing, and trabeculectomy operation we do not want any healing, so that it will function. But there are lots of complications are there, and the whole scenario of not possible in this 10 minutes. Let me guess through. Early leaks, there can be hypotony, choroidals, and a late bleb failure and infection. Let's come to the holes. If it's a tiny holes, just the pressure patching is enough. If the perforation is a 1 to 2 millimeter, give a bursting suture with a 10 or nylon. If it is more than 2 millimeter, it may lead to conjunctival advancement, autograft, or amniotic membrane. This is a picture of a bandage contact lens of 14 millimeter bandage contact lens for a small perforation, and this is a perforation operation after conjunctival advancement. If it is a high IOP and a deep in antechamber, what will happen? It can be lots of things may happen. What you have to do, you have to go for the gonioscopy. It can be the plug sclerostomy due to lens matter, which may require the surgery, or the vitreous, it may require surgery. If there is blood clot, the digital methods may dislodge it. And if the iris 2% pilocarpine, if it doesn't work, go for the laser. This is the laser with the plugging of the peripheral iris. You can see the picture. After the laser is open, you can get the round pupil. With the cortex, you have to remove with the surgery. Encapsulated bleb, typically seen between 2nd and the 4th week. And the recent meta-analysis shows superiority of medical therapy over the needling. But needling we still style. There are two pictures of the early encapsulated bleb and the late bleb, which needs some operation to clear it off. A small needling, it is already described by Sharmila, I am just skipping it. If it is shallow AC, if you want to classify it, it's a grade 1 is a peripheral iris of the cornea touch, a grade 2 the mid peripheral iris and corneal touch, is a grade 3. It's a very dangerous case of corneal touch with the lens. If there is flat anterior chamber with hypertony, leak or overfiltration may happen. Look for presence and extent of the choroidals. Is a grade 1 and 2 anterior chamber, no detected leak, minimal CD. Two pictures are there. You can use cycloplegic atropine, reduce the topical steroids, and you can use the large therapeutic contact lens. Hypotony, flat AC, grade 3, anterior chamber, shallow, kissing choroids, maculopathy. This is one of the dangerous things may happen. Reformation of the anterior chamber with the BSS or the visco or air, whatever you like initially. And if it doesn't work, resuturing of the flap and drainage of the CD by the retina surgeons. Flat anterior chamber, high IOP, suprachoroidal hemorrhage or malignant glaucoma may happen. 4th and 5th post-op day, sudden hypotony may happen. Aphakia, normally seen in aphakia, congenital glaucoma, old age. Overhanging cystic bleb, overfunctioning. You can give compression suture, intrableb blood injection or cryo laser. This is overhanging bleb. Or you can go for the amputation at the limbus. These are some of the pictures of the late complications. Late blebs. You can see the small late bleb is there, small one is there downstairs. You can give the autologous blood injection. Not walking. Okay, I'm skipping it. Let's see if it works or not. It is inside.
Yes, sir. Actually, videos run नहीं कर रहे थे आपके. I just want to tell you from first time. Yes, sir.
Can I take a little time, Dipanjan? For the pen drive. Huh? With the pen drive, you see.
Okay. You show the videos only.
Yeah, only videos.
The videos are there now. Videos are there.
Yeah.
Actually, videos are there. So you want to?
Okay, the autologous blood.
It's running. Yes, sir. Accordingly.
It will help me. This is the autologous blood. You can see a small leak. Just wash it off. The patient's own blood is taken by the sisters and slowly injected in the subtenon space. Slowly it goes on. You can see the blood inside the Gleb area. There's a subtetanous place. And if it enters the antechamber, it is much better. It works much better. Next. Next. Labely conjunctival advancement. Very small leak. You can see the pressure with the fluorescence. Small leak is there. And give me pressure. The leaking is there. Shallowing of the anterior chamber. So what you do with the spatula? Just clear it from the limbus. Once it is cleared, cut with the angle of anesthesia, open it. See where the raw area or the conjunctiva is cleared off. It's very thick. So you have to pull it down and just suture it. It works much better. Next. Donor scleral. It's a donor scleral patch if you have it from the eye bank. If it is a large leak, you can see the tenons and also the Gleb leak area. The donor sclera is taken, it's trimmed, cleared off, and just patch it, put it over it, the Gleb area, stitch it down with a 10 or nylon, and the conjunctiva is closed by the edge of the white drill. Next. One. Amniotic membrane. Just one more. It's amniotic membrane. See it. This small leak is there. First, with the sponge, you have to clear it off, make it raw a little. Here the amniotic membrane is spilled with the sponge. Slowly take it off. We're giving glue over the raw area of the conjunctiva. Put the amniotic membrane over the raw area. Just spread it down, trim it at the limbus area. You can give us large contact lens, or you cannot give a large contact lens also. Just make it sure it is attached to the raw conjunctiva. The other complication, due to shortage of time, I am leaving it here. Thank you very much for patience hearing.
So, we are coming to our last talk, our keynote address by Dr. Shams Mohammed Noman, who is coming from Chittagong Eye Infirmary and Training Complex. And he heads the units of glaucoma and cataract. And he will take us through the advantage of collagen implant in trabeculectomy. Be tuned, we will have a question and answer session or little discussion at the end of his talk. Dr. Noman.
Honorable panelist and dear audience, it is my privilege to be here as an invited speaker at All India Ophthalmological Congress. And now I am talking over the surgical management of glaucoma. Collagen is an option. So I have no financial interest doing this. So I want to start with a case. Mr. X, 45 years, diagnosed case of right primary open-angle glaucoma with left vasculitis retinae. Vision in the right eye is 636 and in the left eye no perception of light. Intraocular pressure is very much increased in the both eye. 45 and 35, with 4 anti-glaucoma medications, I mean the highest medications. In the left eye is totally hazy, fundus cannot be seen. In the right eye it is an advanced cupping. So this is the picture of the right eye, where what is the only eye of the patient with a advanced cupping with advanced visual field defect. So what is the issues to be thought? We need the operation for the glaucoma, and this is an one-eyed patient. So we have to ensure the success. I should not take any risks for postoperative complications like hyphema, hypotony, and raised intraocular pressure and wipeout. He underwent trabeculectomy with collagen implantation, and at day 7, this is the condition of the bleb, and at day 30, this is the condition of the bleb. And that was a very good bleb, and patient eye was survived. So what are the options actually in the glaucoma? Why I did the collagen implantation in that case? We could do the trabeculectomy, but trabeculectomy is still the gold standard operation, no doubt. And the success rate is 70 to 80%. But it is reduced in the complicated cases, and we cannot take risk in case of where the one-eyed cases. And in postoperative complications, it is not very much uncommon, like hyphema, hypotony, inflammation, and it has a moderate expense. I think the less expensive operation among the glaucoma surgeries. Trabeculectomy with collagen implantation, the success rate is increased due to reduced postoperative complications. That is my experience. The total success rate is almost the same as the Mitomycin C and 5-fluorouracil. What is the advantage is the tenting effect of collagen. It acts as an antifibrotic. The problem is it is quite expensive. So and that is a major problem in a Muslim countries, as it is made from the pork origin. There is a religious barrier doing this, and we have to take a lot of permissions from the patient and a lot of procedures we have to do. Valve implantation or tube implantation is another option in the complicated one, but it is a time-consuming, recommended for the complicated glaucoma only. The postoperative complications should be taken in mind, like hypotony, hyphema, tube exposure, tube corneal touch, and sterile mentim. And no doubt this is very much expensive, may not be available in each and every part of the subcontinent of this India. And one important portions what different tubes and valves and what should be used and what should be available, and this depends on the expense, depends on the availability, depends on the patient's condition. So I had an experience comparing between the trabeculectomy and collagen implantation. Total 60 eyes of 60 patients were included in this group. One is a study group, only trabeculectomy, and a control group without implant. With implant, it is a study group, and without implant, it is control group. And we, in the study group, use 6:1 millimeter collagen. It means the atelocollagen and aminoglycans combination. What is the result actually? Very interesting. Postoperative intraocular pressure in both groups was significantly lower than the preoperative level at the last follow-up. The number of postoperative medications is reduced in the both groups, but it is less needed of postoperative medications in the collagen group. And collagen group had statistically significant less complications were observed in this study. And in terms of intraocular pressure, both groups have a very good reduction of intraocular pressure. So no difference between the amount of reduction of intraocular pressure. 4 eyes from the control group and 1 eye from the study group developed hyphema. This is probably due to leaking of blood from the scleral flap angle to the anterior chamber. In the study group, probably this is less due to relative tight sealing due to pressure of the allogen over the flap. So there is a possibility of less leaking. Allogen didn't show any allergy, but biodegradation is slower than the mentioned period of 60 to 90 days. I even saw almost 1 year it was taken to be absorbed, the whole collagen. Postoperative complications like endophthalmitis was not found in this study. This is one of my case where one eye in the case did the trabeculectomy Mitomycin C, another eye trabeculectomy with collagen implant, and that was doing good still now. What is the problem of the MMC? Success rate is more, no problem. Long-term complications, some long-term complications like polycystic bleb, bleb sweating, bleb leak, overwhelming bleb, and scleral menting and hypotony. It is a good one, but we have to think of that complications also. And these are some pictures of like polycystic bleb and some choroidal flap fold in a hypotonic maculopathy. And one of my case where the just see how the bleb leaks occurs from the polycystic bleb, and ultimately I had to do the bleb advancing suture and bleb compression suture to for this patient. What is the advantage of collagen? It guides the fibroblast to grow through the matrix pore, acts as an aqueous humor shunt, acts as an aqueous humor reservoir, and actually it guides the fibroblast in an alternative way, and it makes a tenting, and also it makes an aqueous humor reservoir. Ultimately, long-term effectiveness is more. So this is some steps of doing the collagen implantation. In case of triangular flap, we can place it just over the triangular flap, the apex of the triangular flap, and in case of quadrangular, we can make it more posterior. So shortcomings, we don't do any comparison with MMC. Now it is going on, and I will present it in the World Ophthalmic Congress. Sample size should be more, long-term follow-up is needed, did not include any complicated and secondary glaucomas in this study. So what is the things we should think about the patient? Expense, the success, vision and satisfaction. This is very much important. It is really a very much challenge to satisfy a patient. And residual vision should be maintained. So my message for this presentation, trabeculectomy with collagen does not show any significant advantage over the trabeculectomy alone in terms of intraocular pressure, but immediate postoperative complications are less with allogen implant. That indicates collagen's safety profile. No allergy to collagen is observed, no intraocular inflammation infection is noted. Collagen implantation is a better option, but may not be the best option in case of primary glaucomas. So we celebrate our World Glaucoma Week, 8 to 14 March. Thank you for the patient hearing.
Thank you, Dr. Shams Noman, for your wonderful lecture. Any questions from the audience? We can take questions now. Whom do you want to ask?
Yeah, especially to sir.
Dr. Shumit Chaudhary?
Yeah.
Oh, there is
Dr.
one
Chaudhary.
question for Dr. Shumit Chaudhary.
Yeah, there was a patient I operated 3 months back. It was a case of uveitis. Post-operatively, the patient is fine, but the chamber is very shallow. The pressure is around 10, what we achieved. There is a myopic shift. The chamber is very shallow.
Shumidda?
So should we should we do something or leave the patient just like that? The pressures are controlled, there is a myopic shift, but the chamber is very shallow.
What's the time period?
3 months now.
3 months, you have to intervene.
Okay.
Because the short period you may not intervene, you have to look for the normal set. Yeah. Wait and watch, but now you have to intervene. You make...
The patient is fine, the vision is 6/6, the pressure is well controlled.
The chamber is very shallow.
But the chamber is very shallow. Should we intervene or not?
Is it touching the cornea?
No, it's not touching the cornea, but in the periphery, it's almost touching the limbus.
So what is the choroidals? Are choroidals there?
No, there are no choroidals now.
There are no choroidals. And you are not finding any improvement or deterioration within the 3 months period?
No.
It is kind of a late hypotony when there are no
the hypotony was never there. It was maybe in the initial 3 or 4 days the hypotony might have been there, but now it is stable. But the only thing is the chamber is very shallow and there is a myopic shift.
Was it an angle closure patient?
No.
It's not an angle closure
patient.
So probably post uveitis it is.
It was a uveitis.
It is a period of ciliary shock maybe.
It's 3 months already.
Yeah, 3 months you can.
No, from the very beginning it was shallow or
Yes,
just?
from the very beginning it was shallow.
From the beginning,
From the first post-op it was very
That's
shallow.
better to leave it.
What is the cataract status?
No, IOL is there. We did a combined
Oh,
surgery.
it's an IOL.
Yeah,
If the patient can
You want to
shift,
answer?
patient can see, is a 6 patient with?
yeah, with -3 myopia.
What is your gonioscopy
How many?
showing?
Gonioscopy is very shallow. It's very shallow.
No, but can you see
No,
the
no,
angle?
no angles
You
can
cannot
be
see
seen.
any structure.
Cannot see.
Any synechia?
No, the chamber is very shallow. No synechia is being.
Gonioscopy, is there any synechia there?
No, the chamber is so shallow.
He can't see.
We cannot see any synechia.
The total space. Yeah, Manish, want to say something?
Yeah, one comment, sir.
You
We had one patient like this which almost had 3-4 months shallow AC. So
now, when did the shallowness started?
it started around 15-20 days after surgery.
Okay, and
Remained
it
shallow.
stayed
There
for
was no
4 months.
obvious choroidals also. But on UBM we found there was supraciliary effusion and the patient resolved with a 2-month course of oral steroid.
Exactly.
So
I wanted to
maybe
tell
could
you
be
that
possible.
you can give a charge
We
of
gave
steroid.
initially a lot of steroids, but now we have stopped the steroids. The chamber, the only problem with the patient, with us is the patient doesn't have any problem except myopia. What I am feeling is that the chamber is so shallow that tomorrow it may not increase. That is the only fear.
That you can always follow up.
So we should just wait and watch, or we should we deepen the anterior chamber?
You should do an UBM and probably give a second course of oral steroid for a period of time, at least for a month, to see whether it is improving, because this is a case of prolonged ciliary shock
I don't think
after
even if you give
uveitic patient.
steroids, the chamber is going to deepen.
No, the
up.
chamber is not going to improve,
Yeah.
and I think you just wait and observe.
Okay.
And basically, if it was an angle closure, such chambers are there after you operate on angle closures. So
That's normal.
I think you should just wait and observe. Do nothing. Yeah.
Okay, thank
So
you.
just a counter question.
Yes.
What if he went back and formed the AC?
What is?
If he formed the anterior chamber with a viscoelastic? This is just a query.
It might raise the pressure.
Pressure may rise.
No, may.
May, but why
Why do you want to
since
intervene if the
everything is
pressures are normal? That is the
No,
question.
because if we cannot see the angle, then maybe we may end up with PAS subsequently with the
Already PAS is there.
zipping up of the angle.
PAS is there.
Have you ruled out pupillary block? There's no.
Yeah, there is no pupil.
I think we have Professor Jesse Das
Yeah.
in the
in the audience.
Sir, please help us, because we are not able to come to a conclusion, consensus.
Thank you. Thank you very much. My approach will be a little different, conservative of course. What I'll do is the first step is, I'll give a bottle of mannitol to him and dilate the pupil with atropine and let him remain supine for some time, and maybe for half an hour, 1 hour, and see what is happening to the depth of the antechamber. Second approach, suppose it doesn't form, I won't hesitate to do a PI, put the pilocarpine in 2-3 days, 4 days time, and then do a PI and wait for 3-4 days, 5 days. It doesn't do a hyalodotomy, anterior hyalodotomy with a laser, and that conservative treatment might work. And you see, you just dilate it for some time, maybe for with atropine, stronger ones, and see what is happening. In most of the cases, it does work. And if he's on Diamox or on Dorzox drops in the other eye, is he on Diamox?
That also can. No.
He's not on Diamox or any Dorzox drops in the other eye. Then I think you
This should be the
try
approach.
this for a week or so, should work.
So,
if
sir,
it
you
doesn't
feel
form-
that this is basically something that is
Malignancy.
a pre-malignant glaucoma
means-
sort of a
No,
thing?
that is some amount of fluid accumulation behind the lens.
Lens,
IOL.
okay.
That is what is causing it.
Okay.
See, the
So
moment
if you do an
dilate
UBM,
it-
then
UBM will give us additional information. UBM will be whether there is accumulation or whether there is supersedary accumulation of the
UBM will not
fluid.
give anything.
But if it is just accumulation of little aqueous behind the lens, this should work.
Sir, if it doesn't work, can we go for the antechamber reformation with any
Doesn't work. Just antechamber reformation doesn't
Reformation
work.
doesn't
Even if you do it a Helan, just 2 days, 3 days,
It goes off.
Yes, then it goes back.
And mind it, his vision is okay, and there is no other
Yes.
thing. So our intervention should be more of conservative.
Conservative management.
Yeah.
So I
As you
would
told,
also
sir,
like to do.
the PI is already there. It's a large PI, and the pupil is already mid dilated. So do we need to do the maneuver which you are telling?
I think in spite of this thing, you give a bottle of mannitol and atropinize it. And watch for 2-3 days.
Sir is thinking
and that PI
in
may be
terms of
blocked with
pre-malignant
the
glaucoma,
lens. So
where there can be a situation where there is anterior
rotation of the
shift,
body.
So
anterior shift, and
And
probably
patient has become
the pressure will rise, but it is yet to rise.
Exactly.
So we can just stop it before.
and the patient has become more myopic. That exactly shows that
That's exactly
the
so.
lens has come.
Lens iris diaphragm has come forward.
anteriorly.
Come forward.
So if you take the measures to decompress the fluid accumulation behind the IOL, should serve the purpose.
Okay.
And the first attempt will be to dilate it, and it might work.
Yeah, I think the take-home message here would be you need not always have a high intraocular pressure with an aqueous misdirection. You may also have to think it can happen with a low or a normal intraocular pressure as well. So what I would suggest is definitely you would have to do a UBM, follow the patient very closely. I would agree with Professor saying that we have to use atropine and steroids and closely follow the patient. And maybe you have to repeat a UBM and see. And conservative management is something which I would recommend first, and surgery is the remote thing, and last option, which would be taken only if there is a high intraocular pressure and progression of the disease.
At least, I think persistent inflammation also come into play when we talk about low IOP aqueous misdirection. So steroids has to be given in higher dose. Yeah, so automatically it can happen. If there is no other question, we are actually come to an end to this wonderful IC. And before we thank our presenters and AIOC, I would like to thank the house full of people who has attended the IC on the last day of AIOC. And thanks a lot from all of us. Thanks.
Dr. Norman, do you have problems with collagen being of porcine origin?
Yeah, he told me that.
Now, do your patients refuse?
Yes.
You do get a high percentage? And you inform all of them that this is...
He has to inform, otherwise he will be sued.
Hi, how are you? Good to see you. Thank you so much.
Nice, very nice.